Season 3, which is going to be on pediatric congenital corneal opacities. And I would like to thank the coordinator, Dr. Mehdi, for coordinating this. Thank you so much. And all the experts who are with us today, Dr. Murlidhar, Merle, Arundhati, Bhaskar, Dr. Sunita Chaurasia, as well as Dr. Anshuman Verma. And I'm sure it's going to be a great session with great insights. So welcome everyone to this session, and over to you, the moderators, Dr. Paras Mehta and Dr. Shalini Singh, for the session.
Jan, you can give an introduction of Dr. Murlidhar. Dr. Gyan.
I think there is
Easy.
Yeah, we can.
So on behalf of CSI, I welcome everybody to this session of history. Yeah, historically we select an institute and Paris, and then we thought about doing congenital pediatric corneal obesities, and then Dr. Murlidhar's name came into our mind when we approached him. He was very kind enough to consent to conceptualize this program. So at this juncture, I would officially invite Dr. Murlidhar Ramappa, Head Cornea Service, Shantilal Sangvi Cornea Institute, Child Site Institute, LVP, Hyderabad, to this session. Thank you, sir, for consenting. Dr. Shalini and Dr. Paras has also structured the coordinated this program very nicely. So I'd like to hand over the session to Dr. Shalini. Dr. Paras, please take over.
Thank you, Dr. Gyan.
Shalini.
Yeah, thank you, Dr. Gyan. A very good evening, everyone. I welcome everyone to the Kera Grand Rounds today. At the outset, I would first like to thank Dr. Murlidhar, Dr. Paras, and Dr. Gyan for this opportunity. Before we start, I would first like you to introduce to all the panelists of this Grand Round, although they need no introduction, but to begin with Dr. Murlidhar Ramappa, who is also the keynote speaker for today's session, Head of Services, Shantilal Sangvi Cornea Institute, and Faculty Child Site Institute and Institute for Rare Eye Diseases at LVPI Hyderabad. Dr. Merle Fernandez, who is Director of Kalamanji Reddy Campus, LVPI Hyderabad. Dr. Sunita Chaurasia, Senior Consultant, Shantilal Sangvi Cornea Institute. Dr. Anshuman Verma, Research Scientist, Ophthalmic Genetic Lab at LVPI Hyderabad. Dr. Arundhati Port Thakur, who is a consultant at LASIK Laser Eye Center, Guwahati. Dr. Bhaskar Srinivasan from Code Eye Care, Chennai. And last but not the least, I extend a warm welcome to the executive body of Cornea Society of India. So before we dive into the world of congenital corneal opacities, I would first briefly take you through the classification of congenital corneal opacity and briefly differentiate between some of the most common opacities we come across. So in this presentation, I will shortly take you through the classification of congenital corneal opacities and differentiate between the common causes and how do we approach cases of congenital corneal opacities in general. I have no financial disclosure or conflict of interest. Traditionally, the differential diagnosis for congenital corneal opacity is remembered by the mnemonic STUMPed: sclerocornea, tears in descemet membrane, ulcers, metabolic causes, Peters anomaly, edema, that is shed, and dermoid. Although this serves as an aid to help the clinicians think of differential diagnosis, it does not help to phenotype accurately. This classification given by Ken Nischel should help the clinician understand the cause of congenital corneal opacity, better explain this to parents, and recognize those conditions in which therapeutic intervention may be helpful. So according to this new classification, which is primary congenital, secondary congenital, and secondary acquired, primary congenital comprises of sclerocornea, dystrophies, dermoid, and CYP1P1 cytopathy. Secondary congenital comprises of Peters anomaly, iridotrabecular dysgenesis, primary congenital glaucoma, and acquired will comprise of infectious causes, traumatic causes, and metabolic causes. So when you approach a case of congenital corneal opacity, initial assessment starts right from the history. of prenatal, intranatal, and postnatal, consanguinity of the parents, and family history, whether the opacity is unilateral or bilateral, extent of anterior segment involvement, state of the posterior segment, status of the child, systemic status, including any developmental delay, visual function state, social circumstances of the parents. Ocular evaluation, as we are dealing with infants, examination should be done under anesthesia. Horizontal corneal diameter measurement, dimensions of the opacity, preferably photographic documentation, which will help us to follow up the opacity and the change in size and morphology. Degree of opacity, which means the visibility of iris details, pupillary silhouette, and red glow. Corneal vascularization, if present, in how many quadrants or absent. Abnormalities of iris or angle, which can be assessed with gonioscopy. Lens status, present or absent, and if present, if lenticular opacities are present. IOP should be measured with Perkins tonometer, dilated fundus evaluation, and in case of opacities where visualization is very difficult, investigative modalities like B-scan, ultrasound biomicroscopy, and anterior segment OCT should be helpful. So this table shows differentiating features in some of the most common congenital corneal opacity, starting from primary congenital glaucoma, which you can see in this picture has shown to have increased horizontal corneal diameter, HAP striae with raised IOP and disc changes. Congenital hereditary endothelial dystrophy, which will have marked corneal thickening and opacification. Endothelium may be rarely visible. Mucopolysaccharidosis, where you can see marked hazy cornea with disproportionate thickening and grayish-white appearance. Although this table simplifies, but each disorder may have a varied spectrum, which can be seen in this slide, where you can see a varied spectrum of congenital hereditary endothelial dystrophy. Hence, this session will help us understand spectrum of the most common disorders in congenital corneal opacities and how do we manage them. So to conclude, precise diagnosis is essential for congenital corneal opacity. Early detection and recognition of ocular and systemic issues prevents long-term vision impairment and developmental delays. Imaging, histopathology, and genetics aid accurate diagnosis and surgery planning. And tailored management, whether conservative or surgical, can help for lifelong care. Thank you.
Thank you, Shalini, for setting the tone for this session. Now, I would like to invite Dr. Muralidhar Ramappa, who is very well known for having innovative different ideas for different surgeries in pediatric age group. And he would be talking to us on limbokeratoplasty in sclerocornea. Over to you, Dr. Muralidhar.
Yeah, thank you, Dr. Paras, for the opportunity. Also, I thank Cornea Society of India for this opportunity. We'll be sharing, our experience of doing a limbokeratoplasty. Basically, limbokeratoplasty, wherein we are using the donor cornea as well as the donor limbus. I'm basically repurposing this particular technique for a sclerocornea. Traditional limbokeratoplasty, it is also called as a keratolimbal allograft, was used for a severe chemical injuries in the 80s and 70s, where even before the concept of stem cells came into vogue. I do not have any financial disclosure. As we all know, the sclerocornea is one of the bugbear of any anterior segment surgeon. They tend to have an abysmally poor outcome following a keratoplasty. They often have a dense corneal opacification, extensive stromal vascularization, ill-defined limbus, which not only have inadequate palisades of vogue and a poor limbal architecture that fail to maintain the corneal homeostasis following a keratoplasty. Besides this, you have a crowded anterior chamber where extensive corneoscleral iridocorneal adhesion, that is one of the biggest risk factor and a poor prognosticate marker for a keratoplasty. Therefore, conventional keratoplasty deem it to fail in this. So if you look at a phenotypic description of a sclerocornea, so you can actually see the anterior limbal line where it demarcates the silhouette of the cornea, which is not only small, flat, and opaque, and densely vascularized. And if you look at, the corneoscleral junction is much beyond. It's basically, the conjunctiva, which is inserted much anteriorly. which brings in lot of blood vessels to the cornea. Hence, you have an extensive vessels. This particular picture again depicting the anterior insertion of the conjunctiva. If you also look at the limbal silhouette, is very irregular and characterized by, the huge amount of both superficial and deep vessels, and the corneal surface seems to be very poor with the limbal palisades. In addition, when you do UBM, they also have, as I said, not only crowded chamber, an extensive iridocorneal adhesion that makes these cases are much higher risk for a keratoplasty. So one has to distinguish sclerocornea from the peripheral sclerocornea. It is also labeled as a cornea plana. You can see a central cornea which is much more flatter, and your palisades are anteriorly inserted. We could actually see each of these palisades here in IMAG image, and you don't have adequate pigmentation here. Cornea is much flatter, smaller, and these cases do not need any corneal transplantation. Again, OCT, the central cornea, is relatively thicker compared to the mid-peripheral cornea. They do have a poor endothelium, and these cases simply needs a simple refractive correction. They have in a tune of 10 to 14 diopter of hyperopia that has to be identified and recognized. Going back to histology of sclerocornea, they not only have a thickened abnormal corneal epithelium, and it is also debatable based on the causality of the sclerocornea. They may have even a conjunctival epithelium, which do not support postoperatively once you do keratoplasty. Bowman's membrane is absent. And the stroma, if you look at carefully, they have an extremely thick, irregularly arranged collagen fiber, which are reminiscent of that of a sclera, and a deep vascularization, which also given by both episclera and the scleral vessels. And endothelium is absent, that even make the long-term graft survival is a poorer because you don't have a peripheral endothelial reserve. And a most important factor, angle recess, is compromised, have a significant iridocorneal attachment. Again, this histopath, shows that all futures, and hence, historically since 1970, last 50 years, the sclerocornea is not a good indication for a keratoplasty. That's what the belief, and that was a literature created both Western world, both North America as well as European literature shows that. And we also did a immunophenotyping, including epithelium in most cases, except in a PAX6 abnormality, they're that type of cornea, including keratin sulfate, and it does belongs to natively that type of cornea. And what is most important to maintain the corneal milieu following a transplantation is a presence of a good limbal stem cell. Need to have an extremely good palisade upwork. In this context, we tried to image. While I worked with the Ken Ishel almost 12 years ago, we did this work. We were able to capture not only the number of limbal stem cells and adequate number needed to maintain the normal homeostasis. So this brings out to the hypothesis. So in these cases, do we need to retain preserving the host limbus? So when we image, some of these cases may have a normal looking palisade upward, but they're inadequate to maintain the corneal milieu. In such cases, it's very important to provide a donor limbus in order to maintain the ocular surface. This was a simple hypothesis. Should we have a host limbus or a donor limbus? The host limbus, as we know, it is inadequate. Again, this series of OCT images actually showing the architecture of the limbus and comparing with the one which has a control. This is a control where you have a healthy limbus. For every square millimeter, you have a more than 5 palisade of Voges. In comparison to this is a particularly one of the sclerocornea case where they're not only inadequate in number, this seems to be very abnormal, cannot be compared with that of a normal control population. So we were convinced in such a cases, for instance, if you look at this particular case, sclerocornea, which has an extensive vessels, This is possibly due to PAX6 mutation. In addition to sclerocornea-like manifestation, they had a partial aniridia. In such cases, if we embark keratoplasty, it doesn't support the post-operatively. We had a recurrent epithelial breakdown. We were unable to heal PED-like defect, and the graft went on to fail. And what causes sclerocornea? There are 8 different set of genes which are responsible for a causation of the sclerocornea. In Indian setting, nearly 50% of the autosomal recessive, particularly South, where parental consanguinity very high, they tend to have an extremely severe form of the sclerocornea, have a poor palisades. And of course, in the West, there are other genes are also have an associations, and nearly 50% of these cases can have underlying glaucoma. If you look at various series right from 1970, they tend to have extremely poor outcome. If you look at in terms of a first-year outcome following a keratoplasty and a sclerocornea, only a 1/4 of the patients will survive. So with this background, since we are dealing with the cases, not only cornea is opacified, they have an inadequate palisade. Hence, we decided to use a donor limbus, which is rich in palisade. So we ideally, choose a young donor tissue, which has a less than 6 hours of death to preservation time. And in this particular cohort, we have at least 41 eyes of 28 children, which completed at least 6 months of follow-up in the last 12 years' time. And we ensured at least 1 quadrant of limbus is included while we punch. And also, we combine torsorrhaphy, special lenses, and we put an immunosuppression in such cases. This is an index case. If you look at right and left eye image, again, it is an elliptical cornea, which has a poor limbal palisades and a dense corneal opacification. You can actually see a corneoscleral junction and anteriorly inserted a conjunctiva. The limbal line is migrated. Whereas in a left eye, you can actually see at least 1 quadrant of the peripheral cornea is relatively clear with a pigmented limbus, meaning the left eye has a decent prognosis if we do a keratoplasty than the right eye. So this is a surgical video. So extremely flat and a microcornea. And this was a 6 and 7 millimeter graft. I make sure I also preserve the host limbus. And there is an extensive corneo-iridocorneal adhesions carefully without damaging, separating. And this sclera is also variably thin at areas where it is extremely thin. And we've used a very young donor, which has a conjunctival frill. I trimmed it up excess conjunctiva because, always scared about contamination. And ensured, this limbus actually goes under the superior eyelid so that, it's well preserved. These are the post-operative images, right and left eye. And we've used a, special contact lens. I don't have any commercial interest. About 1 week, the child missed a follow-up. You can see the right and left eye image. Right eye has a contact lens with penetrations. It's doing pristine clear, whereas all sutures by, the 2nd week, I think this is about 19 days after a corneal transplantation, almost all sutures are loosened up and a massive stromal edema. So possibly impending rejection. But in this particular case, I have to immerse child on an aggressive steroid and could recover. Although graft is clear, there is some amount of haze is still persists. Okay, in a 2nd eye, that is the left eye. And see the child, at the age of 2 years and a variety. So we've completed, 70 cases so far with this technique. And normally, we never used to offer a surgical intervention. So even if you look at post-operative, the donor tissue here, having a limbus, that is a donor limbus, all cases, they were maintaining the surface very well. And I have included in this particular cohort, those which have finished at least 6 months of post-operative follow, 41 eyes of 28 children, and predominantly female gender in our. Although, the consanguinity is much higher than what it is indicated here, many of them, they do not forthcome with that. These are very young children. And most cases, surgery done between 4 to 6 months of age. And if you look in terms of nearly 88% achieved, better ambulatory and a functional vision, and a 40% achieved 2800 or a better. Considering these are the normal growing children, this vision is extremely important for their overall development. And in terms of complication, if you look at, the rejection seems to be one of the important risk factor for the graft failure. And it's seen in nearly 20%, and most of them had an irreversible rejection. Again, it is the first 6 months is the most crucial point where we tend to remove suture and manipulate. That is the time we have to be very, very cautious. And beyond 18 months, the risk of rejection and a graft failure significantly comes down. And about 10% of them had a cataract, and glaucoma was observed in about 12%, and 6% needed a palliative procedure to control glaucoma. If you look at in terms of cumulative overall long-term graft survival, 68% at 1 year, 58 at second year, and nearly 50% of the graft had a clear graft even up to 3 years. This is so important. As a pediatric cornea specialist, I was able to keep the visual axis clear and ensured that, during the neuroplasticity, these children have been taken care. So rejection being one of the independent risk factor for the graft failure, therefore it is so important to educate mother to pick up any subtle sign of a rejection. So this is again an index case, pre and a post I am showing. I was able to capture only the right eye specular image. You remember left eye, had some corneal age because at the day 19 had a massive, rejection, which was reversed. Although graft is clear relatively, there is still some amount of haze. Hence, I could not capture the specular in the left eye. In conclusion, children with a significant stromal opacification due to sclerocornea or a phenotype due to any of these underlying genetic mutation, one of the most common being a PAC6, which is a very tricky to deal and handle with, can gain a significant visual improvement by doing this, technique, limbokeratoplasty, where we're including the donor limbus. And a perioperative measurements like using a specialized bandage contact lens. This is to minimize, surface inflammation and also delay the premature loosening of suture. And these cases were selected, some of them on a systemic immunosuppression. If the child is beyond 6 months, we will have the discussion where a T lymphocyte, mechanism has kick-started. In such cases, may need a systemic immunosuppression. Otherwise, a topical immunomodulator is sufficient in most cases. And also it was used in high-risk grafts, the repeat graft, or if it does have a precious eye. In such cases, I kept the immunosuppression. If the parents are willing to take that extra mile, keeping that child on immunosuppression. So we know the cumulative graft survival, little over 50% at the end of 3 years. It's a very, very rewarding compared to what literature actually shows. So therefore, limbokeratoplasty can be safe, effective, and seems to be, viable surgical alternative to conventional penetrating keratoplasty. However, long-term multi-center studies are needed to define case selection, long-term outcome. When do we use a topical versus systemic immunosuppression, and also donor criteria? Thank you for your patience listening. And if there are any questions, I'll be happy to take.
Thank you, Dr. Muralidhar, for that wonderful talk. It was amazing to learn that at least 50% of the cases have clear cornea and probably an ambulatory vision. And this must be probably the largest series, 71.
Yes, madam. I've included here only 41 eyes. We have completed a little over 70 cases now because they don't have, I've included only those which have a more than 6 months follow-up.
It seems that these cases do require institutional care, but how do you size your corneal graft in such cases? And again, intraoperatively also, there must be a lot of, issues which you would you like to give some tips about that?
Yes, absolutely. Great question. So I generally have a good pediatric anesthetist We keep the child in a negative Trendelenburg position, head in elevated, hypotensive anesthesia, ensure your PCO2 level less than 30. And sometimes I may give a 1.5 cc of retrobulbar injection, apply a super pinky so that your eyeball is extremely soft. Because these have a normal lenses. Most of the complication, as you figured out, they're technical in nature. So you end up damaging iris, lens, our lens can extrude. And yeah, all the steps are so important, and wherever feasible, even we have to apply a flaring gas ring to minimize all technical complications. So slow decompress, I tend to use a cohesive viscoelastic here, and I keep my donor button prepared even before I enter anterior chamber. So I have quick transition, I don't spend in an open sky. And one of the good question you've asked me about, I need to define the limbal silhouette. So in this particular case, surgical case, it is only 6 millimeter. I need to respect and preserve as much as a host limbus, because anatomical landmarks are not reliable. And also peripheral cornea and sclera is extremely thin. We may not have a good opposition. And in many areas, you may not get even a good ledge. Okay, so I think the graph the reason behind taking a 1 millimeter with disparity here, to begin with, cornea was extremely flat and chamber was very crowded. By changing 1 millimeter, I'll be changing the radius of curvature by 1. So I'll be inducing about 6 diopters of myopia that is much more desirable, and also keep the same time, chamber much more deeper, minimizes the risk of, peripheral anterior synechial formation. And of course, it may contribute, lessening the risk of glaucoma as well. And additional thing, I use a specialized contact lens, tarsorrhapy to retain contact lens and minimize the, eye rubbing related, suture related complications. Thankfully, because of these strategies, we could minimize suture related complications. And mostly I resort to 0.1% topical tacrolimus right from the first week. And I start the glasses as soon as I have a window reflex. Once you have it, because these are young donors, they tend to have, again, pristine cornea, epithelium is intact, should be able to give them a, correct, appropriate optical correction within a 1 week, most cases. And when do I resort to systemic immunosuppression? Older children is above 6 months. And with the conjunction with a pediatric advice, I tend to use tacrolimus, or cyclosporin is one of the first drug we use here. So the systemic immunosuppression tend to keep in the first year, where risk of having a graft rejection is much higher, since we manipulate the sutures and so on. So with this technique, as you rightly said, nearly 50% of them have a clear visual access even up to 3 years. That means, even if this graft fails beyond 3 years, you have a window of opportunity to revisit and do something for these cases. So any risk is worth to minimize the risk of amblyopia. So that's my message.
Very true. And do you try to kind of, because these corneas are thin, so your donor may be thicker than these corneas. So you try to achieve a surface kind of alignment rather than the...
Yes, you're right. We have to try to
have a lot of surface problems, especially.
True. So we need to avoid override. We need to have an extremely good opposition. And there are also risk of having a subtle, post-operative leak, because there is always a disparity between the graft and host. And some of these cases, Srinivas, Dr. Moll will agree, they tend to develop peripheral anterior staphyloma, because, the peripheral cornea is extremely thin. And that's a risk, if we do not respect the limbal, margins. So therefore, my trifine is always well within the limbus.
Any comments from Dr. Bhaskar, please?
Yeah, so a nice talk, Muralidhar, as usual. So my technique is slightly different. The basic idea being you need to be aware that in sclerocornea, there is a limbal deficiency also. So your surface has to be stable. So one option is what Dr. Muralidhar said, where he's using the limbus from a donor graft. At SN, what we were doing earlier, and Dr. Vinay also has done a couple of cases where we were using the concept of what is called as a limbal sparing keratoplasty, where we try to reflect the limbus. Because like Muralidhar showed, the actual anatomical cornea, if you look at it, is actually beyond what you are seeing as the limbus. You're only having the conjunctiva coming in anteriorly. So if you're going to trephine it in the center, then you are limited by the graft size that you can do. In his case, he showed a 6 mm, but a lot of times you'll have only a central 4 mm area of your cornea which you will be able to trephine. So that becomes too small to actually trephine, because the amount of endothelial cells that you will be transplanting is also less. So the idea would be to make conjunctival nicks, take it to the cornea like how we would do for a CLAU kind of a thing, reflect it 360 degrees. Then you can actually put in a slightly larger graft, and then you stick the entire conjunctiva and the limbus back. Depending on the amount of limbus which you clinically feel is there, you can decide to just stick it back, or you could top it up with an allogenic sled from the donor cornea. Advantage what in this technique was, I'm not too worried about the sutures, because the sutures are always covered under the conjunctival flap. So I really don't have to be worried about suture loosening or suture removal as such. The only difference that his technique, he also used the contact lenses, which we did not use. So that's something that we probably will have to look, because anything to protect the epithelium will probably aid in a better survival of the graft in the long run.
Great points, Dr. Srinivas. Cases which have a extreme, elliptical cornea, where, your vertical diameter is, sometimes 2 or 3 millimeter, where I do as the same technique. Resect, we do what is called as the limbal translocation. You push the limbus back and go ahead with the regular technique of doing a keratoplasty. Yes, I do in a certain cases. You do have that kind of exaggerated elliptical shaped cornea. It comes in a different shapes.
Yeah. It's not one size fits all. Each case is unique. You need to be aware of whatever way we can try to get the best that we can give to our patients. And I just wanted to ask you, what's special about the contact lens? It's the fenestrations which allow a better oxygen permeability?
Exactly. So it has 8 fenestration with the internal channels. So each time when child blink, the contact lens tear film, it exchanges and not only maintain the good decay value. And as you said, secondly, they've also shown it tend to retain, prednisolone in the contact lens film for 9 hours. I've not tested that hypothesis, but in a future idea is that, so mothers need not have to instill every hourly drop. So this can also have a systemic, ramification using every hourly prednisolone in a neonate in both eyes. So that was an idea also to minimize the drug toxicity and the systemic effects. Dr. Merle, since you have a huge experience dealing both Peters and sclerocornea, just want to, listen from you.
Yeah, so I think you guys have covered it all. Basically, if you have the conjunctiva more anteriorly on the cornea, then resecting it and then doing the PK, which allows you to get a slightly larger diameter, is what works. But I think the cases that you've described, how many of them actually had associated cataract? Because then the outcomes would definitely be poorer. Because when you do any other secondary intervention along with these pediatric grafts, the outcome is not great. So if they have a disorganized anterior segment, then you would have issues if you've had to tackle the lens at the same sitting.
Yeah, great question, Dr. Mal. I don't know the exact number. I do remember, even if there is a significant cataract, I don't do combined procedure. Because, you tend to normally remove sutures in about 6 to 8 weeks time. And allow them, the wound healing, everything is complete. Then as a second surgery, I go on, take care of the cataract surgery. And we can't put IOLs in these cases. It will be left aphakic. I tend to preserve the capsule. I know, PCO is 100% risk, but I want to, maintain that barrier between anterior and a posterior chamber, because, maintaining graft for me is a top priority for the initial 2 or 3 years. So I leave them aphakic, give them aphakic glasses with the intact PC.
So I think the other thing that you usually land up encountering is because, as you mentioned, the recipient bed is unhealthy. And so you often have suture tract leaks. So your graft-nose junction may be fine, but from the suture tract on the recipient end, it starts leaking. So I think the larger contact lens, when you use it,
Yes.
and if you bury the knots in the tract, you're prepared for this, then you can actually get away with it. But sometimes the suture tract opening itself is so large that you're unable to seal that there. So that becomes a challenge. I think repositing the conjunctiva or over it would tend to help, but you might have shallow ACs in the post-op.
Great points. Absolutely.
Before we move on to Dr. Shalini, there is one more question on a chat box. Somebody is asking that how do you space transplants between two eyes? Like, what is the time interval you would like to keep
Yeah,
between the
great.
two eyes? This is very
Yeah.
crucial.
Yeah, great questions. I'm a little conservative surgeon. So every case following a transplantation, I anticipate and preempt, there could be, donor-related infection. Okay. So the mostly, as we know, they manifest within a first week if they are very fulminant infection. And second thing, this also allows me to assess how good is the healing in a child. And thirdly, I also assess how committed parents are. If I'm convinced, if there are at the end of 1 week, graft is doing, there are no, issues related to the donor and the healing, which is expected lines, and the parents are extremely committed, then between 2 to 3 weeks is the, timing between the right and left or left, whichever eye we choose. So 3 weeks would work out very ideally. Dr. Mal and Bhaskar, you have any difference in opinion here?
Generally around a month, within a month's time, if they are ready for it. The issue will be when one eye is normal and the other eye alone has the opacity. Then the question is whether you would want to subject the child to a surgery, and the parents have an expectation. They expect it to be normal. So that's a difficult decision that you have to take, because whatever you do, your vision is going to be suboptimal, but at least to the extent that you can give the child a vision. So that is a challenging situation. If it's bilateral and they are ready and the outcome in the first week is reasonable, then yes. But if it is significantly asymmetric, with one eye having an anterior staphyloma and other eye having, say, a severe Peters kind of a thing, I might just operate the eye where I feel there's some amount of vision potential and just leave the other eye, because the outcome is not going to be very, very good in an anterior staphyloma.
Absolutely. And even I always give a benefit of doubt to the better eye. I always tend to operate first is my better eye. And once carefully look at, and if necessary, we do the second eye, the worst side.
Yeah, but I think, when you operate two eyes, even keeping a 3 to 4 weeks gap, I think sometimes there's the immune response is so, so high in these kids that they tend to come to you with rejection even after a week of the second eye surgery. And that's something that you have to be so careful about, because if the parents don't realize it, then you can even lose both the eyes.
Absolutely.
So I have just one question. Since we are talking about the outcome, so is it possible that the outcome of this limbokeratoplasty depends upon the underlying gene also?
Correct. You're right.
Okay, so
If it is a PAX6, it is a master controller gene. So they tend to have extremely poor palisades. They're destined to develop aniridic keratopathy nearly in 70% of the cases. And in a technique what Dr. Srini was showing, so even if you preserve host limbus, they are inadequate, insufficient to maintain the corneal homeostasis. Therefore, that's an idea concept behind using a donor healthy limbus, which have a much better palisades and they're very healthy. And a 4 clock hours, 1/4 of limbus is adequate to maintain. And these are the normal, small size graft. Dr. Vanity has asked, are there any comparison? Yes, Dr. Vanity. So my own cases where I've done a regular conventional keratoplasty, they tend to do extremely poorer. So nearly 90% of these cases end up having a failure in the first year itself. So therefore, I think some time ago, about 7 or 8 years ago, I decided I should not be doing keratoplasty for a sclerocornea because of a failure rate. Then once, we slowly made this, technique alteration and modification. So we ended up having a good outcome.
Yeah, in fact, if you're just doing a conventional PK, most of the time you'll end up having epithelial defects, which will just not heal. And that will be the primary cause for failure. So by about a month and a half, the graft is already failed. You'll be doing multiple amniotics to trying to stabilize it, but it will not really work. So having members there, even if you have to do a PK for, say, an aniridia, I mean, the outcomes are very poor. The fact that unless you are supplementing the limbal epithelium, the graft doesn't survive. The epithelium just breaks down and you end up with a failed graft.
Right. I think, Srinivas, you also worked on this concept, in the 1960s and the 70s. There is something called, in a pediatric case, you have a window where inducible immune tolerance. Because, for 6 months, the child has only humoral immunity, which is passively, the child has gained from a mother. So from 4 to 6 months, we don't know exact window, each child may have a different window. That's where, T cells start producing from thymus, spleen, reticuloendothelial system. This is a time frame. If we catch that child and perform a keratoplasty, the child have something called a tolerance to the new graft. So therefore, it start accepting that graft as our own, and therefore, we can actually mitigate the lifetime risk of having a rejection. Srinivas, you want to?
Yeah, the only issue is the challenges of surgery becomes much more when you operate a smaller child. You are probably, and the inflammatory response is going to be higher. Your probably rejection subsequently might be lesser if you're able to mitigate that initial, your surgical skills are optimal and you're able to mitigate the initial inflammatory phase, then probably your long-term survival will probably be a little bit better. But that's a decision that is always difficult to make, because the child is, especially in eyes like sclerocornea, where you have very small anterior chamber, you're so worried about having inadvertently having the lens come out or having to do a cataract surgery, where the prognosis then goes completely berserk.
Absolutely, it's a big trade-off. Infant young tissue, the tissue is so pliable, chamber crowded, and even a blood uveal retinal barrier is so immature. So you may have a lot of fibrinous reaction. So plethora of complications in a perioperative period. So one has to really make that trade-off between doing too early surgery versus having a tolerable induction of T cells. Yeah, it's a tricky concept. Not many people practice, but when we see in reality, some of these sclerocorneas have lost to follow for years together. There was one case surprised me. 12 years later, he's coming with a clear graft and have a pretty decent vision. Child is in a 10th class now. He was never on any medications. He just lost to follow. How do you explain, such cases where having a both clear graft, possibly, the early surgery?
In fact, Dr. Geeta had done one therapeutic graft in a 15-day-old child, and the child did not come back for follow-ups after that. And the child has now come back recently after almost 10 years with a clear graft, stopped steroids, everything after that 1 month. But it was probably within that 1 month or 1.5 months period where the immune system was still developing and it got adjusted.
Absolutely. Thank you.
Fantastic. In the interest of the time, shall I request Dr. Shalini to continue with the further, talks by fellows and presentations by the other consultants? Dr. Shalini, over to you.
Yeah. Thank you, Dr. MD and Dr. Bhaskar and Dr. Mal for the great discussion. Now we have case-based discussions by our fellows. So first, Dr. Maria will be presenting on differentials of cloudy cornea. Maria is our outgoing fellow. So Shabina ji, can you share the video, please?
Good morning, everyone. I'm Maria Doctor, and today I shall be presenting on a case of corneal cloudiness. So my patient, a 7-year-old male, second child born of a third-degree consanguineous marriage, was brought by his parents with complaints of blurring of vision and whitish appearance of black portion of both the eyes since the past 5 years. He had an uneventful birth history, and his family history was also non-significant. On general examination, he was well oriented at time, place, and person. He had a short stature with scoliosis and abnormal gait. On further examination, it was noted that he has coarse facial features, large head with frontal bossing, short neck, telecanthus with epicanthal folds, bilateral hazy corneas, depressed nasal bridge, low set ears, thick lips, tongues with micrognathia. Also, he had multiple joint contractures and short, stubby, spindle-shaped fingers, along with presence of an umbilical hernia. Rest of the cardiorespiratory system was normal, and there was no presence of organomegaly. Also, he had normal intellectual development. On Ocular examination showed visual acuity of 2400 and 2200 in right and left eye respectively, and examination showed diffusely hazy bilateral corneas, which were also thickened in appearance. Rest the anterior as well as the posterior segment examination was normal. The differentials of mucopolysaccharidosis, shed, and congenital glaucoma were kept in mind. Mucopolysaccharidosis patients usually have coarse facial features with corneal cloudiness, multiple joint and skeletal dysplasias, with or without presence of neurological features or cardiorespiratory abnormalities. While patients with shed have bilateral thick corneas with corneal edema, and the DM shows beaten copper appearance. Since this opacity is present since birth, these patients also usually have nystagmus, while patients of congenital glaucoma have ophthalmos with megalocornea and characteristic triad of pain, lacrimation, and photophobia. Also, there is presence of HAB striae and presence of glaucomatous disc damage. Keeping all these things in mind, a diagnosis of mucopolysaccharidosis was made in our patient, which was confirmed by doing urine analysis and genetic testing. So mucopolysaccharidosis are lysosomal storage disorders which occurs due to the deficiency of enzymes required in the degradation of glycosaminoglycans, which results in accumulation of these abnormal glycosaminoglycans in various body tissues. They mostly occur as autosomal recessive form, and based on the various phenotype and the defective enzyme involved, it is classified into various subgroups. The systemic features involve coarse facial features, growth retardation, cardiac valve abnormalities, respiratory difficulties, intellectual and behavioral problems, and hearing impairment, while the skeletal features such as gibbous, paddle-shaped lower ribs, cortical bone thickening, claw hand with coxa valga together are known as dystosis multiplex. There are various ocular features such as corneal clouding, glaucoma, retinopathy, and optic nerve abnormality can occur in varying frequencies in different subgroup classifications. The management mainly involves enzyme replacement therapy and hematopoietic stem cell transplantation. However, both of these are only effective during the early 2 years of life, and they do not help in reversing the damage which has already occurred. Pitts et al. Showed the results of enzyme replacement therapy, and they too suggested keratoplasty in patients where the corneal damage has already occurred. While Eric et al. Showed the outcomes of penetrating keratoplasty in these patients, and they suggest that since these patients have an intact endothelial function, hence DALC could be a better alternative. The outcome of DALC has suggested that recurrence was not noted in any of the corneal grafts during a follow-up period of about 3 years. Recent reports have shown that in vivo confocal microscopy has revealed characteristic vacuoles in the basal epithelium as well as the stroma at around 9 years post the transplantation. And ASOCT also has shown hyperreflective opacities which has started to occur in the stroma. Long-term outcomes of big bubble DALC has shown that big bubble DALC seems to be an acceptable surgical procedure while performing DALC in these patients. We too went ahead and performed subsequent DALC for both the eyes in our patient. And our patient regained a visual acuity of 20/80 and 20/60 in the right and left eye respectively. Hence, to conclude, mucopolysaccharidosis is a multi-systemic disease requiring multidisciplinary approach for its timely diagnosis and initiation of appropriate systemic therapy. It has characteristic systemic features, and big bubble DALC has good surgical outcome in these patients. Thank you.
Thank you, Maria, for the great presentation. So we now have a couple of questions, Dr. Muralidhar and Dr. Sunita. So how do you distinguish cases of mucopolysaccharidosis and congenital glaucoma, as both of them are associated with high IOP and a cloudy cornea? Are there any tips or anything you specifically look for?
Sunita?
Any of the panelists can take the
Yeah,
question.
Dr. Mal, Dr. Arundhati.
Yeah, can I see in MPS? First of all, in if there is a congenital glaucoma and it's early on, you'll get the characteristic ophthalmos appearance. MPS takes time for the GAGs to get into the cornea, and there will not be ophthalmos. There will be just opacity which will be there. The patients are asymptomatic in MPS, while in ophthalmos there'll be watering, tearing, the pain, all these sort of things will be their acute features. While in MPS is a more chronic disease, so really it's not very difficult to distinguish between the two. And of course, taking the patient up for examination under GA and checking the IOP and the glaucoma will give it away. Yeah, thanks.
I would just like to add that in the end, if the differentiation is difficult, in that case, the genetic diagnosis and genetic testing would help to distinguish the disease.
Yeah, but Anshuman, it's not so difficult to distinguish clinically. So, yeah.
Dr. Anshuman, if you could shed some light on enzyme replacement therapy and who would be the ideal candidate for enzyme replacement therapy and how are the outcomes of this therapy?
So, enzyme replacement therapy, first, it is not readily available, but nowadays, due to the international connections, they are available. And the criteria for this, as you mentioned, that as early it is diagnosed, the therapy would more benefit. So that is the criteria that one should distinguish and diagnose the disease and then start the replacement therapy.
So I think cost also is kind of quite prohibitive. It's very challenging for our patients to afford the therapy. So I think that's another factor that we have to take into consideration when we recommend it.
Okay. So Dr. Mal, in these cases, as it was mentioned in the presentation also that big bubble DALK has been seen to have good outcomes, but how do you really decide whether to go ahead with DALK and PK, because the corneal haze is also quite significant. We cannot assess the endothelial function. So how do you decide between DALK or penetrating keratoplasty?
So usually you'll be operating these kids early on, right? So they don't tend to have that much of endothelial involvement. And so therefore, I think when you do if you're able to do an ASOCT under anesthesia, you'll be able to appreciate if there's an increased reflectivity at the level of the endothelium. But having said that, it's not very common to see that in MPS per se. So I think you can go ahead with just doing a DALK as opposed to doing a full thickness graft.
I think there are no more further questions in the chat box. We can go to our second case, which is by Dr. Reshmi, where she'll be discussing cases of primary congenital aphakia. Reshmi is also one of our cornea fellows from CAR campus, LV Prasad Eye Institute. Yeah, Reshmi, you can go ahead.
Good evening, everyone. Thank you for giving me this opportunity for presenting in Kera Grand Rounds. The topic for my today's presentation is primary congenital aphakia. These are the following abbreviations that I have used in my presentation. Moving to the case, a 2-month-old firstborn female child from Maharashtra was brought to a clinic by parents who noticed a non-progressive whitish opacity in both the eyes soon after birth. Perinatal and the past history were uneventful. Child was born out of third-degree consanguineous marriage. There was no history of similar complaints in any of the family members. General examination revealed a healthy-appearing baby with no evidence of any facial dysmorphism. On torchlight examination, both the eye had microphthalmos with corneal opacity. The B scan of both the eyes showed absence of lens occurs and a grossly normal posterior segment. For a further detailed evaluation, child was planned for EUA. These are the clinical pictures of the right and the left eye taken during examination under anesthesia. In both the eyes, cornea showed a silvery white color sheen with a vascularized surface and an ill-defined limbus. The rest of the anterior and the posterior segment details were not appreciated. UBM was corroborative of a thinned cornea with absence of lens and poorly delineated angle structures. Based on the clinical picture and the investigation, we made a diagnosis of primary congenital aphakia and referred the parents for genetic counseling. We communicated with the geneticist and told about our diagnosis. The genetic counselor took a detailed history and advised for clinical exome sequencing, which showed an autosomal recessive or homozygous mutation in FOXC3 gene. Primary congenital aphakia is a rare anterior segment dysgenesis which is characterized by absence of lens. It is associated with pathogenic variants in FOXC3 gene. It results from aborted lens development during the 4th week of gestation, secondary to failed lens blockade induction from the surface ectodome. FOXC3 gene is located on short arm of chromosome 1, which encodes the fork head box protein, which is essential for development of lens blockade. Mutation in this gene can lead to a broad spectrum of eye abnormalities. A homozygous mutation in FOXC3 gene leads to failure of lens epithelial cell proliferation, which in turn leads to complete failure of lens development. And this failure of lens development leads to aplasia of the anterior segment of the eye. Clinically, the cornea shows a bluish or a silvery white appearance with ectasia and thinning. This is accompanied by an ill-defined limbus with limbal stretching. It can either be isolated or present as a part of complex anterior segment abnormality that includes microphthalmia, microcornea, sclerocornea, absence of iris, anterior segment aplasia, and glaucoma. These are the various clinical pictures wherein congenital primary aphakia has presented along with sclerocornea, anterior staphyloma, and microphthalmia. The absence of trabecular meshwork and Schlemm's canal with an intact ciliary body with eczeema production probably explains the elevated IOP resulting in ophthalmos in these eyes. Posterior segment changes seen in congenital primary aphakia include hypoplastic ciliary process and abnormal vitreous and retinal dysplasia. As normal lens is essential for development of cornea and the other anterior segment structures, failure of lens development can lead to panocular dysgenesis. Aphakia can be confirmed on a B-scan, UBM, or an ASOCT. B-scan can also show any optic disc cupping, optic nerve coloboma, and it can be used to measure axial length during the follow-up period. The ASOCT shows heterogeneous appearance of cornea along with thinning and aphakia. Corneal opacity needs conservative management as literature review shows after PK these eyes land up to become thicycle. IOP needs to be monitored at every follow-up visit as 50% of these eyes can develop glaucoma and it is preferable to manage it with medications as again any surgical intervention can lead to eye becoming thicycle. In long run, these patients need visual rehabilitation. Genetic counseling is recommended to detect the risk of familial recurrence. To summarize, cloudy corneas with a silvery appearance and peripheral vascularization, especially in the presence of glaucomatous enlargement with or without ectasia, should alert the physician to the possibility of congenital primary aphakia. Visual rehabilitation in these children is challenging and the outcomes are often poor because of glaucoma and corneal opacification. Genetic counseling should be offered to all the families in cases of suspected autosomal recessive inheritance of disease. Good outcome in these patients is no phthisis and a controlled IOP. Associated risks include phthisis bulbi and spontaneous corneal perforation. Thank you.
Yeah, it was a nice presentation. Is Dr. Sunita on board?
Yes, Dr. Parashi is there.
Yeah, Dr. Sunita, I would just like to ask you that how common do you come across this condition and what would be your approach to counseling the parents for these kind of children?
Yeah, so it's not very uncommon because, it is just that, like, let's say, quite a decade ago, we were not much aware of this entity. But overall, when we examine any patient who has corneal opacity, I think it is important to get the ultrasound done. And many of the patients have this as an association. So when you see that the B scan or else UBM or anything, when whatever we are doing during anesthesia shows that there is aphakia, then it is best to leave it alone as what everybody has pointed out.
So in these patients, we tell the patient like just a follow-up is required, and the surgery is going to further, cause a problem in the patient. So follow-up is only required, and we just have to monitor the eye condition. Generally, I follow them every 6 monthly because quite often glaucoma may not be seen at the first instance, but later on as they grow up, glaucoma may be a part of, in the course of the management, you may encounter that, and that is the time we require a management in terms of anti-glaucoma agents. So
So
usually
in
that is the follow-up protocol for these condition.
Yes, the cornea is thin and there is a heterogeneity. So how do you monitor the IOP in such patients?
No, cornea generally usually for primary congenital aphakia, usually we see a thin cornea. So they are basically on the thinner side.
Yeah.
Yeah.
So what instrument do you use and how do you monitor the IOP in such cases?
So it's the Perkins tonometry, which is being done for anesthesia, or like during the anesthesia evaluation. But otherwise, there are other indirect clues, like you have to monitor the axial length of the patient of the eye. And when you look at the dimensions of the cornea, so there's an obvious, like let's say if you see a staphylomatous changes happening, and that gives you indirect clue as to the eye is enlarging more compared to what it is. Generally, these are small corneas, but in the follow-up, if you see that the cornea is enlarging more, that's again an indirect clue to the, that the IOP is probably in the higher side, and it has been there for quite some time, because that is one thing which can lead to changes in the corneal dimensions. The other thing is also to monitor the, the optic nerve, optic disc head. So if there's a good optometrist who can, or somebody who, any technician who can do a good sonography, you can actually know whether the, cup disc ratio is stable or whether it is increasing. So all these things indirectly will give you a clue as to how the IOP has been over a due course of time.
I just have a concern. Has anyone tried when the child is about 5 years or more older? I'm just thinking about a Boston K-Pro, a type 1 year. Provided the retina is okay, there is no absolute glaucoma, the nerve is not deeply cupped. Has anyone tried? I'm not aware of any literature on this.
No, I think I can take the question, because we reviewed this condition, and when we look at the interventions being done, so primarily it has been only keratoplasty. So Boston K-Pro, again, I think when the PK has not done well, there's unlikely that Boston K-Pro is going to do well in this situation, because in this condition, the problem is that the ciliary body itself is hypoplastic. So when you do any intervention, because the landmarks are so, ill marked, so when you do any intervention, you'll end up, impinging upon the ciliary body area also. And ciliary body, which itself is hypoplastic, will end up actually causing a problem to the ciliary body. And that is the reason for hypotony. That is one of the mechanisms why hypotony occurs in keratoplasty in these patients. Second thing is that because the lens has not formed, the vitreous is also abnormal. So that also is one of the mechanisms that the graft does not survive. So invariably, these eyes, any intervention is bound to have a problem, whether it is keratoplasty, and I think Boston K-Pro also will have the same fate, rather equally bad fate as keratoplasty.
Thank you,
Just a
Dr.
thought, yeah.
Any more comments from anybody?
Yeah, I think they're also prone to developing retinal detachments. And when you, I've had the, when like Sunita was mentioning, several years ago, probably in the early 2000s, when I happened to do a PK for one of these kids, when suturing the donor cornea to the recipient bed, the sclera was extremely, extremely thin, and it was very, very elastic. And then it started kind of buckling up with the suture that I was using. And that I ultimately developed a retinal detachment erythritis. And that was when I decided never again, these eyes should not be touched. I think also an increase, they are a little bit photophobic, but if there's a sudden increase in the photophobia and some lacrimation, that's another clue that their pressure has gone up.
Just coming to the topic of...
Paras, I can make a comment.
Yeah,
So
sure.
any child who's having silvery white corneal appearance, which unlike of a sclerocornea, when you image them, you don't see a lens. And these corneas being extremely thin, these children have a extremely good ambulatory vision. They're able, some of these children able to, we have now 400 plus families, and they have a pretty decent functional vision, able to identify colors. Some of these children, we have documented 2800 to 2000 vision. They're able to cycle, they're able to take care of their task. And as Merle said, so eye protection, avoiding eye poking, that is eye poking is one of the biggest risks for detachment and hypotony. And also they have to be monitored carefully, no invasive procedures. And what I have done over the time, I measure the axial length and give them a FAK corrective lenses. With FAK glasses, their vision actually increases and they're doing much better.
Absolutely. Many times these patients are kind of striked off that nothing can be done, but probably we can provide them reasonably good vision with FAK glasses and various other means. Do they tolerate even corneal scleral contact lenses?
Okay, great question. I've not tried because these eyes are extremely deformed and children
Yeah,
may
so
have to
maybe
operate.
a lot more flatter cornea and very
True.
difficult to customize that.
Yeah, an important thing is the genetic counseling. Since it is autosomal recessive, I'm sure parents must be carrier. So it's important to get the genetic counseling. Just look for a FOXC3 mutation. If the child has a FOXC3, then you screen the parents and you can determine what is the risk of next offspring having a similar problem. So at least we should make an attempt to the same family should not have a second child with a congenital aphakia.
So can I ask one question for the house that how do we decide and which are the centers where genetic this counseling is possible and how expensive that is? Or, I mean,
I think all tertiary centers or any systemic tertiary center which has a good pediatric practice, meaning general pediatric practice, should have a geneticist and a genetic counselor. And an Indian government has identified 8 center of excellences, right from AIMS, all AIMS, including in South India, there are a few hospitals have a center of excellence for rare diseases, and they should be able to offer a pre-genetic testing.
and would they be able to do gene mapping and everything?
Yes, absolutely.
So is it
Absolutely free of cost, yes.
Okay, that's great. Dr. Shalini, shall we move on?
Yeah,
We,
I think
we had wonderful points coming out from this case.
Yeah, thank you for the great feedback from all the panelists. Next, we go to our presentation by Dr. Neeth Mehta, where he'll be discussing a novel classification-based algorithm for congenital hereditary endothelial dystrophy. Neeth is also one of our fellows at Shantilal Sanghvi Cornea Institute. Neeth, you can go ahead.
Hello everyone. Today I'll be presenting on the classification-based algorithm on CHED, that is congenital hereditary endothelial dystrophy. So we know that CHED represents a rare autosomal recessive form of corneal endothelial dystrophy seen in neonatal age and is presented with bilateral symmetrical, slowly progressive corneal cloudiness, which comes under the heading of congenital corneal opacities. It is definitely challenging in deciding the management of CHED because of a lack of conservative approach and a dilemma in deciding when to operate. Currently, the definitive treatment modalities include various forms of corneal transplantations, that is PK, DSEK, and DMEK, which all come with their own forms of limitations, including shortage of donor corneas, complex surgical procedures, and the reluctance of the parents to have their child operated at such an early age. Apart from keratoplasty, other approaches to be kept in mind include amblyopia treatment, topical agents like NSAIDs and anti-glaucoma agents, and gene editing. So here we propose a management algorithm for CHED aiming to streamline management in terms of deciding between conservative approach versus surgical intervention and how to appropriately time for corneal transplantation in these cases. Here we divide CHED into mild, moderate, and severe groups based on the anterior segment visibility and the anterior segment optical coherence tomography findings. Mild cases include those where the anterior segment details, that is the iris details and the pupillary silhouette, are clearly discernible through the cloudy cornea and with no secondary changes seen on the ASOCT. Moderate cases, on the other hand, includes cases where anterior segment details are obscured but the pupillary silhouette can still be seen, with no significant secondary changes on the OCT. Severe cases, on the other hand, include obscuration of the anterior segment view on slit lamp examination, and ASOCT showing significant anterior stromal and posterior stromal or desperate level scarring. Thus, we divide CHED into these 3 grades. Apart from these, corneal haze in CHED can also be graded objectively using the corneal densitometry, as is seen in this unpublished data from one of the study being conducted in LV Prasad Eye Institute, which grades the cornea into mild, moderate, and severe based on the densitometry reading. One can have a conservative approach in cases of mild cases, which includes optical corrections along with patching and exploring the possible role of NSAIDs and IOP lowering agents. The moderate cases can benefit from a DSEC and to time it as early as possible in order to prevent amblyopia onset and secondary corneal changes. Severe cases can benefit with either a DSEC with superficial keratectomy, or if the extensive involvement of all the layers of the cornea are seen, then a PK can be planned. In cases of undergoing PK, one needs to assess the risk and benefit ratio, the adherence of the parents for diligent post-operative care and regular follow-ups in deciding the time for intervention. Thus, by this algorithm, we try to streamline the decision-making management of CHED based on the anterior segment visibility and the OCT findings. Thank you.
Thank you, Neet. Thank you for the wonderful presentation. So, Dr. Muralidhar, we have a question for you. If you could shed some more light on the use of NSAIDs and regarding patient selection, which are the patients where you would use this agent? How long do you continue? Which is the non-steroidal anti-inflammatory agent you use, and what concentration?
Yeah, great question. At this point in time, we have one particular mutation which respond to NSAID. So it is basically SLC411 mutation related with a Golgi apparatus, which in turn have a downstream pathway which regulates, sodium, potassium, ATPase. So NSAID, nefefenac, we use a lot of nefefenac, which is already time tested. We use in a cataract surgery practice. Same drug we use in a same frequency, that is at 3 times. And its aqueous penetration is extremely good as per the animal experiment. And we also did a cell line experiment, before doing this clinical trial. And about a third of our cases have shown, one of the case I was surprised, in about 4 weeks time, there was 400 microns decrease in the corneal thickness. Okay. So the catch is we have to catch them very early, even before, they have a secondary changes. Ideally, the mildest cases would be good. The reason is that you need to have enough endothelial reserve. This molecule has to go and work. If you don't have the critical number of endothelium, so the NSAID doesn't work. In addition, I also do IOP, reducing agent. Therefore, you would actually go and play an imbibitional pressure. Thereby, transiently, at least you would be able to clear the visual axis. NSAID at this point in time, it's only an adjunctive therapy to delay the timing of surgery and minimize, the risk of amblyopia. At this point in time, it is not a substitute. What is upcoming treatment, in 2027? So mark my word, from January 2027, we are starting gene therapy at LV Prasad Eye Institute. We've got a FDA clearance. It is along with one of the group from UCLA. And animal experiment have shown a successful outcome. Currently, we've submitted our safety and efficacy data. Should be able to, enroll cases from 2027 onwards. But, it would be under 3 years where we can able to manage their, get a specular image. If they have an adequate number, then we go transpect by using an adenovirus. It's something similar to the COVID vaccine. We go and inject intrastromal. One shot is enough. That's supposed to transpect and do the gene therapy, basically. So that will take care of corneal endothelium. They start reversal process and they should start working. So it's a very exciting.
Indeed, it sounds very exciting.
Yeah.
So, Dr. Mon, if you could tell us intraoperatively whether doing PK or DSEC, are there any specific challenges in these cases of shed, something to be kept in mind, some tips if you could give?
So I think non-stripping DSEC is what we usually do. And that makes your life a lot easier because sometimes the visualization is pretty poor. The other thing is obviously because the chamber is a little smaller. So if you're doing a DSEC, you have to be careful not to, not to damage the lens. And other than that, if you can get the child to stay still, then the lenticule should stick.
Thank you. Thank you, Dr. Yeah, sorry, Dr.
Shalini, one of the potential demerit of doing endothelial keratoplasty in a shed is lack of postoperative pristine cornea. So even if you catch very early and do, the cornea is not as transparent as, conventional keratoplasty. That's the only limitation. And these cases can achieve only the best vision 20/40, and maybe one or two have had 20/30 vision. Otherwise, mostly range between 20/80 to 20/100, provided if they don't have amblyopia, other issues. So now we also combine densitometry. Now I have absolute cutoff on a densitometry. Densitometry is an extremely good surrogate measure of corneal opacification. So any cornea where a densitometry less than 40, we can easily go ahead and do dissect. If they're more than 47, that is a 3 standard deviation, then penetrating keratoplasty would be a prudent choice.
Dr. Arundhati, if you would like to give your feedback.
All the points have been very well covered, like, the difficulties in surgeries because of the small, shallow anterior chamber. And as Murli pointed out, the results are more gratifying in PK because in dissect, the results are really slow to show. So I think you have to tailor base each surgery to the degree of opacity that you see in the patient.
Thank you, everyone. With this, I think we'll move to our last case for today, which is by Dr. Anita, where she'll be discussing a case of dermoid in a 5-month-old infant.
Corneal dermoids, a success story. Dermoids or ocular choristomas constitute the most common tumors of corneal limbus. A new grading system based on the analysis of 261 cases over a period of 10 years was proposed by Xiong J. et al. In 2018. The grading system was based on the area of corneal involvement, surface shape, and area of conjunctival involvement of the dermoid. The complication, which is also indications for surgical intervention, include chronic eye rubbing, amblyopia, progressive Dellin, growth encroaching into the pupillary area, aesthetic considerations, induction of irregular astigmatism, inadequate lid closure. We present a 5-month-old male infant presented to us with approximately 8 into 8 mm dermoid involving the superior limbus and cornea, which was involving the visual axis. So the grading was grade 2 corneal dermoid. Our surgical plan was to proceed with dermoid excision and deep anterior lamellar keratoplasty. We expected some surgical challenges in this case, like the graft sizing. Since the dermoid was involving the limbus, leaving the rim of the dermoid tissue superiorly would cause difficulty in wound suturing and irregularity in wound healing. Intraoperative DM perforation would occur and it would lead to double anterior chamber formation. At last, the interface bleeding. So with this in mind, we proceeded with the surgery. It started with applying a superior rectus sutures, and dermoid excision was started with a superior conjunctival peritomy. In every step, the hemostasis was secured with cautery. Layer by layer dissection was done in the dermoid region initially, and the dissection was done meticulously in order to avoid any abrasion underneath the cornea. Then we proceeded with the manual layer by layer technique of deep anterior lamellar keratoplasty in rest of the cornea for 8 mm diameter. So the dissection here was also done very slowly and meticulously with a blunt spatula dissector, and but unexpectedly DM perforation occurred. It was around 1 mm diameter at 4 o'clock position in the host cornea. In spite of it, we completed the dissection and proceeded with preparing the donor graft. The donor graft was prepared by fix and match method was cut with scissors. So the hand fashion graft is then was sutured to the host cornea with 10O nylon. AC was formed tight with air. Next day, double anterior chamber formed. That was noted with a graft edema. So there are many methods, options for double anterior chamber management, like air, gas, and or just wait and watch for the spontaneous resolution, or the rescue technique put forward by Hayashi et al., where the detached DM was sutured radially to the graft host junction and the amniotic patch graft. Here we first attempted with air, but the second post-operative day it was again the same with the same graft edema. So second attempt we just modified the technique. We did a rebubbling of the anterior chamber first and then removed the interface fluid with the cannula in the interface, ironed out all the interface fluid by forming the chamber. Again the chamber was filled to ensure a complete interface fluid drainage. Anterior chamber was again fully formed and the fluid was drained multiple times, and then a full thickness Decimet's membrane Pexi sutures was made on both sides circumferentially and around the area of perforation to seal the leak. So this opposed to the DM to the donor cornea and sealed the leak. So we did a suture removal of the DM sutures at around 2 weeks post-operatively. The graft cleared and the DM perforation area is seen. Take-home points: simple full thickness DM Pexi applied circumferentially around the area of DM perforation would treat the double anterior chamber in these difficult case scenarios. Sterile air is better than gas. Timely management of such difficult scenario with keratoplasty is necessary to prevent the amblyopia. Thank you.
Thank you, Dr. Anita. Dr. Anita is here. Ma'am, would you like to share something or what difficulties you had while managing this case?
First thing was parents counseling. Actually, in this case, it was easier because this corneal opacity was a cosmetic problem for the parents. So they were very much ready to undergo surgery, but the age was also a factor, and then the dissection part of the corneal limbus was little difficult, and the DALK which we did, and we didn't expect this intraoperatively, the DM perforation. And the second day management, again taking to the OR the next day, that was very much difficult due to the anxiety of the parents. Then that we did not explain it previously. So that took some difficulty, like counseling the parents, everything. But the next day also, like after rebubbling, then the third day also we had again the corneal edema was persistent, and this was the last chance we had. So we had to do something to oppose the DM. That was our, and I did not want to fully remove the like endothelium in that because it was a 5-month-old child, and I don't want to do that. So I last tried this, and it was success. So like now the parents are fine, and there is a maybe we have to we are still continuing that amblyopia therapy, and the parents are happy now, cosmetically at least.
Dr. Bhaskar, would you like to give your inputs regarding management of dermoids in such cases, and what if you would have done anything differently?
So, I mean, well-managed case. A couple of points. I mean, anytime that you're taking a pediatric patient for DALC, always tell the parents that there might be a rebubbling, or at least keep them aware about it, because you have to do it under general anesthesia, unlike the adults patient where you can even inject air in the OPD. So it's always nice to just tell them that there is a possibility. The other, I mean, I would have probably also looked at, because you're putting a shaped graft that causes a bit of irregular astigmatism, because you have to mix and match the shape, unlike a proper trephination. So the other option would have been to just have your central 8 mm, and then you can put your rim as a keratolimbal, a sectoral keratolimbal graft kind of a thing there, which will give you the necessary tissue thickness for you to suture, and it will also supplement the limbal architecture there, which is not developed as far as the limbus in that area of the dermoid is concerned. Third, and you saw in the video, you can actually see when they took it up for the suturing time, the air bubble was kind of coming through the inferior perforation. It was going into the interface, and she was mopping it out. That was the reason why it ended up having a recurrence the first two times, because the location was inferior. So once the child is in the normal position, the perforation kind of gets opened, and the fluid again seeps in. I might have probably just taken a single suture in that area if I had to take a suture rather than two sutures. I might have just looked at suturing the area of the perforation tight with a desmetopexy rather than taking three sutures as such. That would be the only difference that I would have probably done.
Can we have quick one or two comments from Dr. Merle and Dr. Arundhati before we wrap up the session?
I think it was a very managed case, and I think the tips given by Dr. Bhaskar is really good. I think especially since we're dealing with pediatric patients who are operated under general anesthesia and adult. I think well put in points and very well taken. Thank you, and all very good presentations, all of them, and good discussions too.
I think the only point is essentially now is the most difficult part of your journey is the amblyopia therapy. But often we find that these patients with dermoid, no matter what you do, their vision does not improve. It remains suboptimal. So they land up with somewhere around 20/50, 20/60, and they never improve, as good as the other eye. So that's something that we have to keep in mind when counseling the parents.
Now the child is having hypertropia also. She's developing, and there is a interface vascularization also, which is progressing. So I'm really afraid whether that would lead to again the opacification.
I mean, it's okay, even if it leads to the opacification. Now you have a reasonable architecture on the other side. So if you have to redo a DALC, it's not going to be an issue. Only thing, in the area of the perforation, you leave a little bit of tissue there. Don't go deeper in that area. Rest, it'll kind of peel off easily.
Yeah. Thank you, sir.
So, like, it seems that we have overshooted the time.
Parents, in case of dermoids, is it? Yeah. So one last question for parents. In case of dermoid, is it the cosmesis which is more important, or is it the vision which is more important for us ophthalmologists? I think we have to meet somewhere in between. Yeah.
So usually you tend to operate these kids just before they start going to school, right? Until that point of time, nobody wants to touch them. So when they start going to school, that's when all the other kids start pointing at them, and then it's important for them to get the cosmesis. But as ophthalmologists, we want to try and give them vision.
Yeah,
but having said that, that is something that you can't actually chase like you would do for the other patients.
Yeah, I mean, the only thing is, if it's a smaller one where the vision is still reasonably good, 6/9, 6/12, you might just observe. You don't really just have to give them glasses and wait for them to improve. But like the video which was showed, where it's already involving the visual axis, if it was a one-eyed patient, the other eye did not have any vision, I might have just looked at doing an optical iridectomy and leaving the child with the vision, because the rest of the nasal cornea was reasonably clear. But if it's involving the visual axis, you don't have a choice. You are trying to operate from a vision point of view. The cosmesis is secondary to the surgical result that you give.
So one of the point is that UBM is a key here. So that will help us, recognize the depth of dermoid. Whether, we can proceed with, it should be always a manual doll. The reason is, the Descemet's membrane terminates at Schwalbe's line. You don't have actual limbus. If you end up doing a big bubble, the Descemet's membrane rips through. So what I would do in such cases is a manual technique, large eccentric doll, which encompassing the dermoid as well as the visual axis. So they tend to give an extremely good outcome. Yes, if it is done in a critical window period, they're likely to have a decent vision. And if the other eye is normal, so that dominates and you end up having a competitive inhibition and end up having a dense amblyopia. No matter whatever you do, they end up having a poor outcome. So ultimately, it is a cosmesis in a large dermoid. In a small dermoid, as Bhaskar already pointed out, we end up having a good functional outcome.
Thank you. Thank you, sir, for the opportunity. Thank you.
So we had a wonderful take-home points from all the panelists all over the session. I feel that we had a less time. I think we should have the session for maybe probably half a day or a full day, Dr. Muralidhar. It turned out to be a wonderful learning for everyone.
Yeah.
And I'm already getting messages from a lot of CSI colleagues that this was one of the best. So with that, we wrap up this session, and I would request Dr. Gyanan Kurmedi to say a lot of things. And
yeah, thank you, Dr. Paras. Thank you, Dr. Muralidhar. Doing these surgeries, it just needs a lot of commitment, not just doing the surgery, but also following them up and taking remedial measures as and when required. Not an easy job. I know where to refer my patients now. Yeah. So Liz and all the members who have attended this show, until the next time, we'd like to say goodbye now. Take care. Yeah.
Thank you.
Thank you.
Thank you.
so thank you, everyone. And
Yeah,
Thank
you
you.
so much
Thank
for
you,
the
everybody.
thank you, Dr.
opportunity.
Muralidhar.
Yes.
Thank you,
Thank
Dr. Mal, Arundhati, Dr.
Thanks,
Bhaskar,
everybody.
Thank you.
Sunita.
Thank you.
Yeah. Thank you, everyone. And all the
Great.
presenters.
Yeah, great job, Shalini. Shalini and Dr. Paras, as usual.
Shalini did the hard work.
Yes.
Thank you. Thank you, Dr. India. Thank you, Dr. Paras. Thank you.
Thanks.
Thank
Okay,
you
bye,
all.
everyone.
Bye-bye.
Bye-bye. Good
Yeah.
night.
Yeah, thank you.
Thank you, Dr. Paras. Thank you so much.